Recording in progress.
Hello, good evening, everyone. I, Dr. Sunil Kotwal, President, Indian Academy of Otorhinolaryngology, Head and Neck Surgery, welcome you all the faculty members and other participants who have joined us today. A special welcome to the key note speaker, Dr. Ahmed Yasin Bhagat, and moderator, Dr. Vidya Sagar. As you all know, our Academy, Indian Academy of Otorhinolaryngology, Head and Neck Surgery is working on the principle of continuing medical education. This time we have chosen an interesting topic that is difficulty in scenario in management of obstructive sleep apnea syndrome. We are also grateful to GSK pharmaceutical company for sponsoring this webinar series. Now I would like to hand over the proceedings to Dr. Vidya Sagar. And before he takes over, I'd like to introduce Dr. Vidya Sagar. His full name is Dr. Vidya Sagar Ramakrishnan. He has done fellowship in sinus and sleep apnea surgery from USA, fellowship in head and neck surgery, microvascular reconstructive surgery from USA, fellowship in pediatric ENT, currently director of Sagar ENT Head and Neck Super Specialty Center in Vijayawada. Immediate past president of Indian Association Surgeon of Sleep Apnea, Vijayawada, former associate professor in ENT, NRI Medical College, Andhra Pradesh, author of 17 publications and 2 journal book chapters, created innovative techniques for the tongue-based obstruction in obstructive sleep apnea syndrome, created innovative instruments for bronchoscopy and foreign body removal, recipients of multiple gold medals in international and national conferences. Now I request Dr. Vijay Sagar to moderate the session and introduce the faculty members also.
Good evening all. Am I audible? Welcome you all.
Yes.
Thank you. Welcome you all. It was a very wonderful introduction, sir. Thank you. Welcome you all for this Indian Academy of Otolaryngology and Head and Neck Surgery webinar series. And on the eve of the World Sleep Day that was on March 15th, we are having this session, which is going to be a good interactive session wherein we are going to have a talk by Dr. Ahmed Yasin Bhagat on difficult scenarios in ENT practice, and which will be followed by a panel discussion which will be moderated on the same topic with various eminent panelists from all across the country. So at the outset, I would like to thank Dr. Mohan Kameshwaran sir, who is our chairman of this Indian Academy, and President Dr. Sunil Kotwal sir, and the secretary Dr. P. Vijay Krishnan, who is actually our president of our academy as well. So without further ado, we'll go on to the first talk. The first talk is going to be by Professor Ahmed Yasin Bhagat. He is the consultant of otolaryngology, Saudi German Hospital, Dubai, UAE, associate professor of otolaryngology and consultant sleep surgery, Alexandria University, Egypt. He is a fellow of European Board of Otolaryngology and Head and Neck Surgery. He is an international SDBS board certified member, and he is also a member of IAOHNS, ISSS, ERS, and he is also fellow of University of Pavia, Italy, Versailles, and UCF and USA. So as he is not available to directly give this talk, I'm going to play his video, which is a pre-recorded video from him. And now I'll just share the screen and I'll present his video. At the end of the video, if you have any questions, please free to ask in the chat box and we will answer them during my panel discussion. Are you able to see the presentation?
Yes.
Good.
Yeah.
Yes, Sagar, go ahead.
About difficult scenarios in obstructive sleep apnea cases.
Are you able to
One of
hear
the
his
most
voice?
difficult scenarios you will encounter during management of
Hello?
obstructive sleep apnea
Yes,
is
Sagar.
management
Yes,
of
Sagar.
complications.
Are you able
How to
to
avoid the
hear his
complication
voice?
and
Yes,
how
yes.
to manage
Yeah.
it if
Everything is
it
good.
Thank you.
happens. I am Dr. Ahmed Yassin Bagat. I am consultant of otolaryngology at Saudi German Hospital, Dubai, UAE, and I am associate professor of otolaryngology at Alexandria University, Egypt. First of all, I would like to thank my father, Professor Yassin Bagat, professor of ENT at Alexandria University, for teaching me everything related to obstructive sleep apnea, introduced me to this field. And I would like to thank my godfather, Professor Claudio Vicini. I inspired most of this presentation from his teaching, and I'm still in debt to his encouragement and continuous education. Thank you very much, Dr. Vijay Krishnar, and for your kind invitation to be with you. I'm so sorry for not being able to attend it live because I'm at that time now. I am flying to Egypt for a couple of days, but so that this is a recorded lecture. But I'm very happy to be with you and to celebrate the World Sleep Day with you in providing such knowledge. So first of all, we need to talk about complications. And in this paper, talking about practice guidelines for perioperative management of patients with obstructive sleep apnea, it stated that all the problems related to different surgeries of upper airways for management of obstructive sleep apnea. Let's start them place by place. So starting from the palate, the early complication related to palate surgery may be transient VPI, velopharyngeal incompetence, wound dehiscence, and exposure of raw area that cause significant pain and dysphagia. And of course, if there is wound dehiscence, there will be hemorrhage and maybe wound infection and bad consequences. Late complications including pharyngeal discomfort, dryness, and or tightness, postnasal secretions with absence of the uvula, food catching in the throat, inability to initiate swallowing, prolonged sore throat, taste disturbances, speech disturbances, tongue numbness from the mouth gag, but the most important of which, either to make the pharynx very narrow due to excessive fibrosis, that's called nasopharyngeal stenosis, or to make the pharynx very wide due to excessive resections and causing what's called velopharyngeal incompetence. The soft palate, the soft palate is a movable structure. It's not something like in the nose, the septum or the turbinates, so you can remove them and make the area wide. No, it's still moving, and it's a valve. It's important for nasal respiration, and it's important for swallowing and important for speech. So the palate should close at the velopharyngeal valve during speaking and during swallowing to avoid nasal regurgitation and to avoid nasal tone of voice, and it should be open while nasal breathing to allow passage of air from the nose downwards. So you need to make it wide but not too wide, and you need to keep the valve function but not very narrow. Loss of the valve function in after palate surgery can be presented with either, as we said, nasopharyngeal stenosis or velopharyngeal incompetence. Nasopharyngeal stenosis means that the passage is very narrow or maybe absent, inability to allow airflow during nasal breathing, and nasal stenosis and the problems related to smell. VPI, that the palate, the free edge of the palate cannot reach the posterior pharyngeal wall, the palate is too short or too rigid. Inability to seal the nasopharyngeal junction during swallowing or during speaking, during phonation, and there is leakage of air and liquid and food from the throat to the nose. Let's start with the nasopharyngeal stenosis, how to manage it. This is one of the most difficult scenario you can see while you are working in the field of obstructive sleep apnea, and the prevention is the best form of treatment. Keep in mind that you don't want to see such picture, you want to avoid happening of this picture. So keep in mind the different risk of different techniques, understanding the increased risk of combining adenoidectomy with palatal procedure, careful operative technique, don't use the electrocautery very wide application, and adequate pre-operative evaluation of adenodectomy or UPPP during the primary surgery is essential for prevention of nasopharyngeal stenosis. We used to do this picture to remove part of the palate to make it wide like this and widen the cavity retropalatal area. But now we are moving from UP3 to ESP, expansion sphincter pharyngoplasty, and this is a very important trick. If you are working on the lateral wall, you will have a very wide space, as you see. You can compare this space with this space, it's comparable, but you didn't touch the edge of the palate like this. So in UP3, the scar is centripetal scar towards the central part of the pharynx, but in ESP the scar is centrifugal scar, so it works with you. So the more time, sometimes after doing a UP3 you will have very nice picture at the end of surgery immediately. Maybe the first couple of weeks after surgery the patient is very happy, but after 3 months maybe the patient is not that happy. He will have a very stenotic segment. So any stenosis manipulation, regardless instrumentation, it will induce more scarring than before, and if you have a bared surfaces, it will lead to adhesions, and it will cause restenosis. Stenting is very difficult to put in this area. It's very sensitive mucosal area, so that's why the surgical treatment of nasopharyngeal stenosis is very difficult and one of the most difficult scenarios you can encounter. But one of the good approaches to treat this problem is the bivalved palatal transposition flaps technique. So if you have a stenosis like this, we need to make an incision and expose a flap. So you will have two flaps. The anterior flap is rotated anteriorly and the posterior flap is rotated posteriorly. So for example, if you have stenosis like this here, so you make an incision here above the site of the stenosis, and you rotate the anterior flap forward and you rotate the posterior flap backwards toward the posterior pharyngeal wall to make an airway behind the soft palate. So for example, this is a case of nasopharyngeal stenosis. You can see this is a pinpoint stenosis here, the patient even complaining of nasal obstruction. So we start here by making an incision at just below the contact point to avoid VPI. We don't want to make it very loud, very wide, and we dissect the first flap, the anterior flap forward, and try to keep the dissection cold dissection. Don't use the monopolar cautery, better to use the bipolar cautery or scissors. And then we remove the scar here, and at this point you can start to divide. This is the anterior flap. Now you can see that this is the hole, the pharyngeal lumen, and now we can divide the muscles laterally here, and to make this posterior flap rotated superiorly and laterally toward the upper incision. You see, we make an incision, and now you have this stenotic segment. We divide this stenotic segment and we suture this area here and this area there. So now this is a new edge of the palate away from the scar tissue. The scar tissue is sutured away from here. It's better to take this in a two layer sutures. First layer with the muscles, and the second layer with the mucosa. And now you can see this is the new lumen of the palate, and this is the new edge of the palate. And now this is 40 days after surgery, a very good space, retropalatal space, and here again this is a picture, flexible picture from the nose. What about the other form, the velopharyngeal insufficiency? It's if there is midline excessive resection or scar retraction, or if there is more rigidity of the soft palate. That's why it's very common after UP3. This is the old technique. We don't approach the central part of the palate to avoid such a problem. So don't over resect the central part of the palate. Avoid a midline over resection, and keep in mind the landmarks. What are the landmarks? The dimple point. You can ask the patient to say ka ka like this, and you can see the dimple of the soft palate toward the posterior pharyngeal wall. So don't go above this dimple point, or transition point. By recognition of the transition from the soft palate and hard palate, and this is the way the uvula is moving to the posterior pharyngeal wall, or the contact point. You can push with your finger the soft palate until it reaches the posterior pharyngeal wall, and this contact point is the critical point. You cannot resect above this point because you will have a VPI. Or the metric point, you can have just 1 finger breadth from the junction of the hard and soft palate, or 2.5 centimeter, or 1 inch from the junction of the hard and soft palate. Avoid to resect more of this. But if it happens, if you have a patient who already been operated by UP3 and he has now velopharyngeal insufficiency, how to treat it? If it is very significant insufficiency, you can use the pharyngeal flap, or if it's not that much, we can do augmentation of the posterior pharyngeal wall by fat. Pharyngeal flap is not a new technique. It's taking tissues from the posterior pharyngeal wall and rotating it forward to the edge of the soft palate. Here is this edge of the soft palate, and it's not touching the posterior pharyngeal wall. So this technique is after Dr. Riccardo Mazzola. He's a plastic surgeon in Milan, in Italy. And again, it's better to use the not the monopolar cautery, to use a cold instruments like the knife, scalpel, or bipolar. If you are using the monopolar, you can use it at the Colorado tip. It's very thin tip and very low energy, so it avoids scarring, because this kind of patients, they have already tendency to produce scarring, so they will have another form of complication, maybe stenosis after doing that, or maybe shrinkage of this flap if you are using the monopolar at a very high power. And then we insert it in the palate. We make an incision at the distal edge of the palate and insert it in a pocket. We can make it like this. We retract the uvula. We make an incision here at the edge of the palate, and we create a pocket like the tongue and groove we are using in the septoplasty. We do the same. Now we have a fresh and fleshy area to receive the flap, and then we suture the flap into the this incision. So you can see this is the flap, and this is how the flap is. And very important also that don't make the flap is evident and exposed to the food, and so the infection will happen. But try to make it hidden. Try to make the flap not under tension. It's very well released. The patient will have some degree of pain after the surgery, like neck rigidity pain due to exposure of the buccopharyngeal fascia here, and the elevation of the muscle flap from the posterior pharyngeal wall. And here's the picture. The flap should touch the palate, but you should have a two sideways to allow the nasal breathing to occur at the end, of course. We also published another technique that's called L-shaped pharyngeal flap. The idea of this is to put this flap in the length of the soft palate to make the soft palate again more lengthy, and it helps in more closure of the velopharyngeal valve. Another way is to inject some materials like fat into the posterior pharyngeal wall, and we also inject in or hydroxyapatite in the posterior pharyngeal wall, and this injection material should be injected into the fixed part of the valve. So we have a posterior pharyngeal wall like this, and this is a fixed part, and we have the palate that's moving and it cannot close the valve, so we need to inject here in the posterior pharyngeal. You don't inject in the soft palate. We inject in the posterior pharyngeal wall to keep like the passavant ridge to allow the closure of the velopharyngeal valve. So this is the first main two complications or two difficult scenarios after palatal procedure, or you can encounter after a palatal procedure. What about the hypopharyngeal surgery? We have two kinds of surgeries for the hypopharynx in treatment of obstructive sleep apnea, either for treatment of the lateral wall collapse or for tongue base hypertrophy and tongue base collapse. For lateral wall collapse is the hyoid bone surgery, and we have two kinds of hyodopexy, either to fix the hyoid bone to the mandible, that's mandibular hyodopexy, or fixing the hyoid bone to the thyroid, that is thyrohyodopexy. And it proved to be a safe technique, this kind of procedure, but among 400 cases you can encounter seroma or hematoma, you can encounter hyoid bone fractures, that's why you need to keep the sutures not under severe tension, keloid formation and scar formation in the neck, and maybe upper airway compromisation due to accumulation of blood or fluid at the tongue base and pushing the tongue base upward and backwards, like what happened in Ludwig angina, and that needs emergent tracheostomy. It happened actually in just 3 cases out of 400, so it's less than 1% the incidence of emergency tracheostomy. So anyway, that's why it's considered a safe and good surgery. It's not a heroic surgery, the hyoid bone surgery. But what about the tongue base? Tongue base, one of the biggest effective techniques in the tongue base, that's Chabot operation, that's opening the neck and exposure of the tongue base and resection of tongue base, and then doing hyoid mandibulopexy. That was very technically demanding procedure, long OR time. It needed feeding tube, nasogastric tube, and tracheostomy with prolonged dysphagia, prolonged hospitalization, and of course cosmetic sequelae. That's why it's now not anymore used. But now we have other options like radiofrequency, tongue base, coblation at the tongue base, transoral robotic surgery, or repose, that is a suspension suture. And of course, as you increase the invasiveness of the procedure, you increase the efficacy, but of course you increase the rate of complications. So what about how to prevent the complications from tongue base? The most important and the most significant complication after tongue base procedure, and the nightmare that any ENT doctor or sleep surgeon can see, this bleeding from the tongue base. So in order to avoid bleeding, it's better to avoid it, to prevent it, not to wait for it to happen and treat it. So in order to avoid that, we need to know the anatomy of the lingual artery at the tongue base area. This important paper, it shows how the anatomy from robotic point of view, I mean from transoral point of view, how to approach the lingual artery transorally. And it's another paper also to compare this versus the course of the lingual artery from the neck. And of course there is an effect of the tongue pulling, and we usually do tongue pulling while doing tongue based procedures. The effect of tongue pulling on the lingual artery course. When you pull the tongue, you will find that the lingual artery becomes more superficial and more medial. So here and here the tongue is out, and you can see that it's more medial and more superficial, so you can encounter it. In a revision of the lingual artery course, it comes out from the front face of the external carotid artery, and it runs above the hyoid bone, and then it goes into the tongue base. So again, here you can encounter it in the hyoid bone, above the hyoid bone. And again, the hyoid bone is, so if the epiglottis is like this and the hyoid bone is like this, so you can find the lingual artery just above the hyoid bone, and for example here's the tongue base, here is the epiglottis, here is the hyoid bone here, and the styloglossus muscle, and you can find the lingual artery here crossing above the hyoid bone and at the lateral border of the epiglottis. So if you are looking at this picture, this is the epiglottis, here is the vallicula, here is the midline glossoepiglottic ligament, and here is the tongue base, and you can find here, if the black dotted line is the hyoid bone, it will be above the hyoid bone, just in front of the epiglottis and lateral to it, so it will be here. So avoid to approach this area. If you can see the epiglottis about outside the border of the epiglottis don't go into the muscle. And this is one of the unfavorable scenarios that can happen while using the cobblator in doing tongue-based resection. If you are not aware of this one of the first cases we had, and if you are not aware of the site of the lingual artery, you can encounter a very significant, and you can see here we are working on the muscle. If you go deep like that, you can find very significant and very severe bleeding, and even with the cobblator it cannot stop, and it's very important. Sometimes you can open the neck to expose the lingual artery to stop that bleeding. So before doing a tongue-based procedure, you should have such instruments: vascular clips, bipolar cautery, what's called the DC bipolar, because it can go deep inside and it can catch the deep vessels, and Yanker suction to retract the tongue base to expose the vessel. In this paper written by Eric Kazarian, it showed that the hypopharyngeal procedures, including tongue-based resection, hiatus suspension, are not really popular surgeries in US, because patients are very reluctant to undergo such procedures, because patients are thinking about, is it really working, those kind of cases of surgeries, and about also if the surgeon is well trained, and about the rate of complications. So post-operative hemorrhage can be one of the most common complication encountered, and the only reported cause of patient death after tours. So the only mortality after tongue-based resection can be due to post-operative hemorrhage, and that's why don't operate on the tongue base except after you are doing a lot of, for example, coblation. You are doing 50 cases of coblation tonsillectomy. If you are doing robotic surgery, you start to do again maybe robotic tonsillectomy first as a training, and then you approach the tongue base. But if it happens, what you can do in this bad scenario, if you have a patient bleeding with the tongue base, you don't need to put a robot again. Usually it's stopped by non-robotic instruments, by DL and a suction cautery, and so you insert the DL until you find the source of bleeding, and with the suction cautery you stop the bleeding. Keep in mind about the intubation and the extubation of those patients. Usually those patients, if bleeding happens, usually they will need tracheostomy to secure the airway until the bleeding is stabilized and the patient is okay, and then you can extubate those patients. And keep in mind also, not only bleeding can happen, because as Erika Thaler proved in University of Pennsylvania, that multi-level surgery is better for patients with more severe sleep apnea. So if you are doing a multi-level procedure combining tonsillectomy and lingual tonsillectomy, for example, if you have a tongue-based resection and they have tonsil at this area, you have to preserve this area. If you don't preserve this area and you complete the resection here and complete resection here at the tonsil, you will find this very bad scenario. A very concentric scar at the level of the hypopharynx. This is the epiglottis, and we are looking now from the back of the palate, and this is the end of this is the tongue, and this is the end of the tongue. So this is one of the very difficult cases you can encounter. So it's better to avoid such cases. You can split the surgery, but don't do one surgery and have this scar. Other complications including teeth and mucosal injury, and as we said, bleeding, of course, nerve injury, and airway compromise due to edema, and that's why it's very important to perioperatively manage the patients. If the patient needs tracheostomy, you need to do the tracheostomy. If he needs overnight ICU, it's important. And if the patient can swallow liquids without aspiration, it's okay. Otherwise, you can put him on IV fluids. Post-operative observation is very important in the first day after surgery. Oral steroids after discharge is important to avoid edema and airway compromisation. Usually, hospitalization depends on the number of procedures. If the patient has a lot of procedures or multi-level surgery, he needs to stay in the hospital for 3 days on average, and you should follow up the patients after discharge to avoid late complications. And we found that the rate of complications and the bad scenarios is increased with the preoperative ASA score, the anesthesia American Society of Anesthesiologists score. The more risky patient, they will have more complications. The number of procedures you are doing, if you do more procedures, you will maybe have more complications. age, BMI, AHI, and other comorbidities can also predict post-operative complications. Finally, before concluding, I want to announce our 14th annual course in Alexandria next May, maybe in 2 months. We will have this course. We will have 2 full days of lectures, cadaveric dissections, hands-on sleep endoscopy, and of course live surgeries. And I invite you all to attend this meeting. Again, thank you so much. And if you need any question, you can send to me. I will be available and answer at your convenience. Thank you so much, Dr. Vijay, and have a wonderful day. Thank you.
That's a fantastic talk by Dr. Yasin Ahmed Bhagat. It is a little bit unfortunate that we couldn't have him here to answer the questions. But if there is any questions, we'll be taking them during our panel discussion. I think it was a wonderful, wonderful talk. He has completely covered the various complications that sleep apnea surgeons would encounter during his practice, both with the palate as well as the tongue base, epiglottis, bleeding. I think he has covered it all. So I think let's move on to the next session. That is going to be the panel discussion. So without further ado, I'll try to share the screen on the next topic. That is going to be the panel discussion on difficult scenarios and OSAS management. Is my screen on?
Yes, it is.
For this panel discussion on difficult scenarios in OSAS management, we have a wonderful panelists, starting from Dr. Dipankar Datta. Dr. Dipankar Datta, you can just raise your hands. Dr. Dipankar Datta is our Secretary of IASSA, and he is the head of the Department of Sleep Disorders, Bellevue Clinic, and Amri Hospital from Kolkata. And next we have Dr. Rahul Modi, who is the consultant ENT surgeon in Dr. L.H. Hiranandana Hospital, Mumbai. He is also the person who is in charge of running the certified training program in IASSA. Dr. Rahul, can you just raise your arms? And then we have our own Dr. Sandeep Bansal from PGI Chandigarh. He is the professor of ENT, Department of ENT from PGI Chandigarh. Dr. Sandeep. And then we have our founder president, Dr. Seemab Sheikh. He is the HOD, Department of ENT, Inamdar Multispecialty Hospital, Pune. And following that, we have a very good friend, Dr. Srinivas Kishore, who is from Hyderabad. He is the director, head of the Department of ENT, AIG Hospitals, Hyderabad. And finally, we have our ever-energetic Dr. Vikas Agarwal, who is the director, Specialty ENT Hospital from Mumbai. Yes. So, without further ado, we'll go on to the difficult scenarios panel. This difficult scenarios, we are going to divide them into the following subheadings, and I'll be asking the questions. The first group is going to be the difficulty in convincing the patient. Number 2 is the difficulty faced due to infrastructure unavailability. And third one is the difficulty in choosing the right modality for that particular patient. And the fourth one is due to the difficulty due to previous surgery or the current surgery or due to the anatomical reasons. So these are the subheadings. We are going to go ahead and we'll try to get the best out of the eminent panelist here. So let's go on to the first question. This is actually a very interesting question to our panelists. This is actually asked by one of our CTP fellow who has started his practice 2 years ago. So he is an young, talented ENT surgeon who has completed his fellowship and CTP in OSA. He has started his OSA practice. He has started to mobilize the patient, motivates the patients, explains the patient's problem, creates the awareness about OSAS, and follows the protocols very diligently, select the patient for the surgery after giving a good CPAP trial, and then selects the proper procedure for that particular patient. Till then, the patient is continuously with them, and as soon as he tells the procedure or the surgery to the particular patient, the patient goes ahead to a kind of a famous OSS surgeon in his neighborhood, gets the surgery done, and comes back to him for the follow-up, saying that, Doc, you're explaining very well, you're giving a very good follow-up, you're answering my questions very well. So this is the situation our young ENT surgeons are in. So I'm going to ask our esteemed panelist. Let me begin with Dr. Dipankar, who is the secretary of IASSA. How well you're going to tackle this situation? What is the answer that you're going to give him? How are you going to motivate the ENT surgeon who has started his OSAS practice? Dipankar?
Hi, Sagar.
Hi.
The question is, I must say, is a very unique and is a terrible question to answer, but extremely practical.
Yes.
But I firmly believe this is exactly the scenario what we have all passed through. So it is a kind of tuning of the mind and a kind of sensitization and acceptance of a young budding surgeon. Yes, unless and until I pass few years in my career, I will have to face this kind of scenario. Probably all of us during our early career have faced this. So we have to encourage our CTPs, our young surgeons, our young next generation. They don't get disheartened. It is your duty. You just do your job. Whether the patient will ultimately do his surgery, undergo his surgery under your care, or get it done by any senior surgeon, that is not your prerogative. You'll do your job, because all of us have experienced this during our early career. This is nothing new and nothing to get disheartened. Just be positive and do your job. This will be my message.
Thank you so much, Dipankar. Dr. Rahul, you being the head of the CTP program, is there anything that you would like to say to encourage the young ENT surgeon?
So I feel given the stage of awareness that we are in, I am very happy that the patient actually underwent a surgery and chose that route. So that's the positive, I would say, that he trusted your advice. Execution, I would feel, doesn't matter. And I mean, that would be true when say a cochlear implant surgeon is starting out. That would be true for any head and neck cancer surgeon who is starting out, that the patient would naturally incline to go. But the patient will respect your inputs. The patient will respect your guidance, and it will hold in good stead. Once you start developing a few white hair, you will just have to say surgery is required and patient will get converted. So don't get disheartened, and continue identifying the right patient and counseling the right patient towards the right intervention, and it will pay dividends.
Thank you, Rahul. I think I'm going to take this question to Dr. Sandeep also, because he is running a wonderful PG program there in PJ Chandigarh, and I am sure that he would have faced such scenarios in his practice. We would like to take his input as well. Dr. Sandeep?
Thank you, Sagar. I think as far as PG program is concerned, they are at a very nascent stage of getting exposed to the sleep surgeries first. So I haven't faced that kind of scenario at present because the PGs are still learning and then they move on to the different parts of the country. But this is a very, very like practical problem which may be faced by the at the initial stage by our CTPs or by the young budding sleep surgeons. And as Rahul has put it and Dipankar has put it, I think there's nothing to get disheartened. We all have a learning curve and we all start somewhere fresh. And then we go on to build up our own practice. I think it takes time for any kind of surgery for that matter. Why only sleep surgery? It will be for any kind of surgery. The better you counsel the patient, the better the patient is, conscious about that you are guiding him right. They will definitely start coming back to you. And one can always start with the minimal invasive surgeries, you know, uh, and then I think you've already start with an uncomplicated surgery. I think that's a very, very thing, the right way to go about it.
Can I
Uh,
add, Sagar?
Vikas, do you want to add something?
Just the last thing, that everybody has said that it's pretty natural that this patient will go to a more experienced surgeon who's your senior colleague. The only thing which we have to, like a junior has to keep in mind is that when the patient has come for a follow-up to him, problem that he will face is that if he feels that something is not just completely right, if he makes a comment on that, this patient will again go back to the senior doctor and spoil the relation between the senior and the junior. So it's better that when I was a junior, I would refuse to do follow-ups of my senior. I would say that fine, if it's an emergency, I'll have a look, but it's the operating surgeon who should follow up. For any emergency, I'm there, but you go back to the senior surgeon, do the follow-ups with him so that you get your best. You understand what I'm saying? Because
Yeah, I got it.
have burned
I
my
got it.
fingers.
Because the surgeon who operated should have the follow-up. So if he misses the follow-up, he will also not have the track of it. But
And then if you say
still,
something,
he
then
can
it's
also
going on.
answer the questions, whatever he has, but the main follow-up should be with the primary surgeon. Is that what you are saying?
Yes,
Yeah.
yes, you can follow an emergency situation, but never follow up with a operated patient of a senior, because you say something, it will go in a wrong way.
Got it. Srinivas, you have anything to say, or can I go to the next
I think
question?
Seema was wanting to say something.
No,
Seema?
I think the only thing that you would I would say to the younger one, look at the positives, like everybody said, and look at the positives that he actually came back to you. So if he did come back to you, he has faith in you. So look
Yes.
at that. That's something that you look in the positive side. And I think in today's world, everybody is talking good about everybody. So I don't think anybody should be commenting about anybody, neither you about the senior or the senior. I'm sure the seniors would have also known that you have seen the patient and come to you. Right?
Okay.
So I'll quickly sort of say something, Sagar, if I'm allowed
Yeah.
to.
Yeah. Please, Srinivas.
Yeah, so the very fact that the patient came back to you again, even after getting the surgery done by another senior doctor, is saying that he has the confidence in you.
Confidence. Yes,
He
perfect.
is definitely going, if he's not gotten it done, he's going to get back with some other patient because now he's more aware of what the problem is. He will be your biggest advertisement. I think that is the proof in the pudding.
Perfect. Wonderful answers. So next we will go on to the next question here. This question is especially to my friend Dr. Rahul Modi. This is a patient who is a 58-year-old male who has been diagnosed with obstructive sleep apnea. He is actually a doctor himself. He was not tolerating the CPAP, and we followed the protocols, and he underwent the surgical corrections for obstructive sleep apnea. Postoperatively, immediate post-op, he was doing okay, but then gradually he started saying that his symptoms are slowly returning back. His postoperatively flexible scope shows the velopharynx is wide open, the tongue base are wide open, but still the patient is having the symptoms of OSA. And again, the patient underwent a sleep study and then a CPAP trial was given. The patient is not happy with the CPAP as well. So what are the options do we have for a patient who is having such a kind of history? And why is this patient still having the symptoms in spite of having a good surgery? Dr. Rahul?
Yeah, hi. So, I mean, this is a scenario where, it is in a way, a sleep surgeon's nightmare that you have done a good job, you've executed well, but the patient is come back. And I would say it is again going back and treating him as a fresh patient. You go back to the history, you look at the severity of the OSA. I mean, whether this patient is operated by me elsewhere, I would also like to see what his sleep study was earlier, what were the reasons he underwent the treatment, evaluate the patient all over again, like a fresh patient, and take it forward from there. Primarily, I would look at what is the severity of the disease currently compared to what it was earlier. What are the motivation factors for the patient? I mean, a lot of time patients can use CPAP but do not want to use CPAP. So that is one of the things. And see, surgery is just part of the treatment armamentarium. Even if the patient has not had relief, we can always have other things that we can look at to improve CPAP compliance post-operatively if the patient is not able to or not had a good response. The weight of the patient, I mean, it starts from the evaluation of the patient, weight of the patient, and then you look at other factors. I mean, I see that you have started him on acetazolamide, zolpidem. So you look for other factors which are like, the non-anatomical factors
Perfect.
to improve sleep apnea. But generally what happens is surgery will sometimes improve only part of the, so to say, anatomy also. If there is a retrognathia at place, those things and all will not be addressed. So you should look at the anatomical as well as non-anatomical factors. But a lot of times it's just a patient mindset that you need to work around and get him comfortable with the condition. So,
Srinivas, question to you on this same patient. This patient, I think I just put the slide that the patient was started on acetazolamide, zolpidem, and oral myofunctional therapy. And immediately the patient started to give symptoms that his symptoms are getting better. And immediately we thought about this form scale grade 3 patients. Do you think he would fall in that non-anatomical factor patient? And if so, how are you going to choose that particular patient so that you won't burn your hands pre-op,
So if you can just go back to the earlier slide, Sagar. Yes. So patient not happy is a very, very diffuse term. All right. I would like to basically start what he's not happy with. Number one. The reason why I'm understanding why it's very important is we need to sort of try to get the history right. Okay. Once we get the history right, we should also be able to tally whether what he's saying before the surgery and what he's saying now, is it tallying with the same thing or no? Number one. Number two, as Rahul very clearly said, you need to go back and treat him as a new patient. And most of us actually keep getting bogged down by this weight of patient coming back and thinking of it as a failure. It is not a failure. First of all, we need to understand that the patient symptoms coming back may not be the same thing as he started with. Then you will obviously do a sleep study and try to understand and see if the disease in terms of the disease burden has come down. Namely, are the apneas and hypopneas the same as they were before? Have you been successful in converting all the apneas into hypopneas? What's the oxygen desaturation index? Have you converted the patient from a all position sleep apnea patient to a positional sleep apnea patient? so on and so forth. Now, the very fact that the patient refused CPAP in the beginning itself is telling us that this patient, see, surgery and CPAP both come under the Palm 1 category if you have to give them success. But the very fact that this guy is looking like probably doing well with some of the non-anatomical measures is going to put him either in the Palm 2A or 2B category, not the 3 category, because 3 is exclusively non-anatomical, right?
Yes.
So what you have done, as Rahul very clearly said, is you have actually built a box, I mean, like a building bricks kind of treatment for him. You've done surgery, reduce the disease burden, give him the medication, made him feel better, and maybe throw in some positional therapy as well to, get the desired outcome. And you have to keep investigating.
Perfect. So
Just
I
a small point, Dr. Sagar.
Yeah.
So even when you have highlighted the use of acetazolamide and zolpidem, if we can discuss, so identifying the right hypnotic or the drug which will lower down the arousal threshold, so to say, or rather raise the arousal threshold and make the patient have a stable sleep, should have minimum impact on the airway muscles.
Okay.
So rather
Rahul,
than
can you also point out the 4 important factors, non-anatomical factors that we need to consider? The
Right.
4 the poor muscle responsiveness, the high
Right.
loop gain.
So-
Just quickly,
Yeah.
briefly.
So quickly, we have what Dr. Sagar is trying to refer to is basically essentially a construct of sleep apnea that over the last few years we have realized is far more important than just correcting anatomy. When we are correcting anatomy, we are focusing, if you look at the table in front of you, the first thing, we are correcting the peak rate value of the patient. However, there are other factors such as the arousal threshold, loop gain, and the muscle responsiveness also contributing to the pathophysiology of these patients. The palm scale in front of you divides this patient depending upon the contribution of the anatomical and the non-anatomical factors. The
Yes.
first factor is a highly collapsible airway, which is highlighted in yellow, which is essentially your typical Kumkaran-like kind of a patient, or someone with very extreme retrognathia or like a syndromic kind of a facial structure. When you come to the palm scale, which is essentially majority of patient, it is a combination of anatomical and non-anatomical factors, where 2A, there is primary anatomical contribution. 2B has a combination of anatomical and non-anatomical. When we say non-anatomical, it comes through the arousal threshold, the loop gain, and the muscle responsiveness. And lastly is the palm scale 3. And I would say palm scale 3 in the Indian scenario is very rare typically to get such kind of a patient for us, because they will typically end up reaching a psychiatrist or a neurologist with a lot of other symptomatology, rarely get a sleep study done. But still, you should be aware these are guys with a healthy, perfectly normal airway, but still have symptoms because of an undiagnosed sleep apnea. So those are the
Is it
Go ahead.
fair to say that if there are 100 patients, around 80% of the patients may have a combination of anatomical and non-anatomical, and around 20% may have non-anatomical factors?
So, I mean,
Approximately,
the
so-
numbers, see, whatever research we have, the real numbers, actually, the initial numbers are not so great. I was discussing with Dr. Srinivas the other day, the numbers are not so great. So what they found is up to 2/3 of the patient may have it. More than the numbers, I would say just keep at the back of your mind. If, say, a patient comes to you who is relatively young, I would say females more than males, and having a combination of insomnia or what we call as COMISA, insomnia and sleep apnea, think about arousal threshold in those cases. Stress is a very important factor in the modern urban life, at least. So, I mean, in a lot of cases, that is important. If this is a 58-year-old guy who's stressed out about a lot of things, he may blame everything on his sleep apnea, but his problem lies elsewhere. So those things have to be taken into consideration. In terms of, we don't have a large series of patients where we can ascribe incidence of, anatomical with non-anatomical factors. Point being, every patient, you should keep these factors in mind and assess it. So just to complete my last point, for arousal threshold, there is a drug called Dayvigo or Lemborexant, which has recently got approval from FDA. and which is found to be safe in mild OSA patients also, because it works on the orexin pathway rather than working on the GABA pathways, which our typical, benzodiazepines and the zolpidem, so to say, work on. The Z class drugs work on. So my preference will be to go on that. They are slightly expensive, and the evidence is kind of like generated for that. So rather than zolpidem, I will use a very mild anxiolytic. So I typically go for an etizolam or a Davigo compared to any of the clonazepams or the zolpidems otherwise. But I mean, if the patient is using a CPAP, then I think perhaps it is safer to use any class of drug. But if the patient is not going to use CPAP, and if I'm looking at a drug in isolation, then I will much rather go for a lemboraxant, which is Davigo, or an etizolam, rather than going for a zolpidem or a benzodiazepine group of drugs. Otherwise, I would
Dr.
want
Sagar?
a drug
Thank you.
which
Thank you.
has minimal impact on the muscle tone. That's all.
Sagar,
Sagar?
I wanted to add, sorry,
Yeah.
one point.
Yes.
So this situation which you mentioned is extremely common. It's not a very common scenario that you perform a good nose and palate surgery or multi-level surgery including baseline, everything is open, but still the patient is having sleep apnea and is snoring. One of the most important reasons is that patient does not learn to nose breathe. In spite of an open nose, open throat, he still is in a habit of mouth breathing and everything keeps on collapsing. This is such an important thing that we now put it in our, a protocol that after surgery, they're all put on a chin strap, instructed that you'll take 3 to 4 months to get used to nose breathing, because that's much, much more commoner than the palm scale that we are talking of.
All right. So we have
Sagar?
other question. Yeah.
Sagar?
Make it quick
Just-
because we have very good.
I just, if you allow me, only then I will take
Please.
one point in this regard. Number one, if we consider the sleep apnea in females,
Yeah.
the presentation is always something different. And in most of the cases, the female sleep apneic present with the symptom of insomnia actually. Rather than classical snoring, they present with the symptom of depression, leg cramps, fibromyalgia, RLS kind of symptom, rather than classical snoring and choking. This is one input. And another is the postmenopausal females. Postmenopausal females, their incidence of OSA is much more. And out of that, 38 to 60% of these postmenopausal OSA patients are concurrent insomniacs. So COMISA is extremely common in these female groups. Yes.
All right. Thank you. Thanks for the input. So now let's move on to the next question, which goes on to the challenges in the evaluation and the management. Let me take it to Sandeep, Dr. Sandeep. I think in the evaluation, I think we have the two types of obstruction that we have seen in the anatomical factors. I think we have discussed about the non-anatomical factors in detail now. Now we'll go on to the anatomical factors. In the anatomical factors, I think there are two types of the obstruction. That is, one is the level of the obstruction and the type of the obstruction. That is the level of the obstruction. I think you can tell us what are the levels and the types of the obstruction.
See, the levels right from the nose, then the velum, oropharynx, and the tongue base and the epiglottis, So if you talk about adults. And of course, we need to look at the any static obstructions, like any, if it's a young adult, maybe these days we find adenoids are there up to, adolescent age.
Yeah, we do see
early 20s. So a lot of these patients having adenoids. So maybe septal deviations, some nasal valve area problems, or maybe a nasal mass also to some extent. So we need to look for all static as well as dynamic obstructions. And I think if you're talking about the surgical part, so then the palatal phenotype, I think, would be a very, very important part for evaluation.
Dipankar, the question back to you is, what are the common static obstructions you do see in your practice?
The commonest is septal deviation, number one.
Okay.
Then turbinate hypertrophy.
Okay.
Tonsils.
Okay.
Then adenoid, even in adults.
Yeah,
even
both.
In adult is quite common. And to some extent, this deformed jaw, that is malocclusion and the retrographic patterns.
Okay. And if there is a static obstruction, because the question to you, if there is a static obstruction, would you still ask the patient to get a sleep study, or can we just directly go ahead and address the patient? Or do we need to go ahead and give the CPAP also or not? These are the two questions.
Yeah, so if the static obstruction is in the nose, if you see nose is full of polyps or a grossly deviated septum, large inferior turbinates, is absolutely no point doing a sleep study, sleep endoscopy. First of all, we need to clear up the nose. Now, only if you feel that the tongue base is not large and the patient is willing for a multi-level surgery to clear off everything, and you want to do a palate and the nose surgery together, then you can do a sleep study, sleep endoscopy, and decongest the nose and try to figure out what is happening. Now, you showed a picture of the lingual thyroid. Obviously, when you have an obstruction like a lingual thyroid, you will simply go ahead and operate it, not do anything else for sleep apnea, because this is a very, very common thing to understand that this is the cause of the problem. Right.
All right.
So
Thank you.
irrespective of BMI, AHI, and all those anatomical, non-anatomical factors, you will still go ahead and remove the
Static
obvious obstruction. Yeah.
static obstruction.
So,
Sagar,
Dr. Sagar, with your permission, I'll
Please,
slightly.
Srinivas.
no, that was me, not
That's
Srinivas,
Rahul.
but
Oh,
let Rahul,
CMO.
Yeah. So,
Yes,
let Rahul
Srinivas.
go ahead. Let Rahul go ahead.
yeah. So my thing would be, I will slightly differ there. My thing would be, I would like to see why the patient has come to me. Has the
Okay.
patient come to me for sleep apnea treatment, or the patient has come to me for a nasal polyp treatment? And I feel, given the level of awareness, it is our job to talk to the patient that, boss, you don't only have a nasal polyp issue, you also have a sleep apnea issue. My nasal surgery is going to address only that bit of the problem. You need to understand there is more underlying issues. Like if a person goes to an MD medicine doctor and the person is not aware that the person is having hypertension, it is a duty of the MD medicine doctor to start treatment for hypertension and not just for the cholesterol reports that the patient is coming with. So first is, we need to inculcate that kind of awareness. I would do a sleep study in any patient where I suspect sleep apnea before addressing the problem in general. If the patient is refusing, not interested, wants to, then I would document that. But I would really document, because
So based
surgeries.
on the history, if there is snoring and witnessed apnea, you will still do a sleep study. But then
Absolutely.
in the treatment option, you'll directly address the obstruction,
I will
right?
address, and I'll keep his expectations realistic. If I'm operating a 60-year-old with nasal polyps and I'm not doing anything to the palate or the tongue base, I don't expect his sleep apnea to disappear. I'm
Naturally.
going to tell you that, boss, once I've cleared your nose, your snoring may or may not improve a lot, but unlikely that your sleep apnea will go away. So be mentally prepared that you will go on a CPAP. I'm just making your life easier so that you can use CPAP better. My intention of surgery is to clear out your polyps and not to take you off CPAP, so
Okay.
to say. So
Thank you.
it would be a little more complicated discussion.
I'm going to get to that shortly.
Sure.
I'm going to get to that shortly. But let me finish off giving this message to our listeners that if there is a static obstruction, you can do a sleep study, but you don't need to do a CPAP titration, and you can go ahead and address the static obstruction. Are we all in the same page?
Yes, so I would like to sort of say one point here. See, days are now of litigation and cases and things like that. I think it's very important for us to have some kind of an objective documentation of what his problems are, to have for us some kind of a proof to actually say that, tomorrow he shouldn't come and say somebody else said this. How come you didn't tell me that there is a problem with sleep apnea when I have this complaint? Right?
So you can get a sleep study done, but you
Yeah.
can directly address the static obstruction, right?
But document it.
And document it. Yeah.
I would
make sure that when you are addressing the static obstruction, you have counseled him extremely clearly.
Yeah.
What you are doing it for. You're not doing it for the apnea. You're doing it as a precursor to clearing the airway. which later on you will reassess after you have cleared the static obstruction.
Perfect.
And
Perfect.
then go
I'm
Perfect.
sorry to butt in, Dr. Sagar, again and again, but I would still go ahead with a CPAP trial for these patients. So to send the message that CPAP is a part of therapy, and 5 to 7 day trial is not going to be any harm. If he is not liking, I would like to document, because I don't want that individual essentially to tell that I was not given a CPAP trial. That's all. Because my intention of surgery is here not to cure sleep apnea.
I
Is
mean,
to
it's a
take
kind
No,
of a
sir,
debate, Rahul, because
Yeah.
no,
if
one
there is a
second,
big blockade there, well, there is a
just
very
one.
good chance that the patient is going to fail on a CPAP trial,
That's
right?
fine. That's fine. So I have documented that, right? I have
No.
documented that failure by giving him a trial. It doesn't add too much to the cost of the therapy per se, and you can get it on a rental basis. So just that. I would not like to extend the discussion further, sir. Sorry.
Yeah, thank you. Dipankar, the question to you. If
Yeah.
there is no static obstruction in your office endoscopy, and if you feel this patient is having a dynamic obstruction, what would be your way of evaluation for that particular patient? You
I
would go
will plan
ahead with
for,
the DICE and
yeah, I will plan for DICE.
okay.
I will plan for DICE. I will counsel the patient for sleep endoscopy. I will explain him whatever the static evaluation, what you have done in the office is basically the static obstruction. I will explain in very shortly the dynamics of obstructive sleep apnea, and I will tell him the sleep study will tell us about the confirmation of the disease and the severity of the disease, not telling anything about the dynamics.
Okay.
Drug-induced sleep endoscopy will guide us exactly what is the roadmap, what are the dynamic structures creating the block during nighttime of your sleep. So I will straight away plan for DICE.
Okay, perfect. So if based on the DICE, you do see there is obstruction, but still these are the patients you will definitely counsel them about the CPAP trial, and then only you will put your choice for the surgery, right?
Absolutely. Each and every one of my patients receive at least 7 to 15 days of CPAP therapy. And I document that compliance or non-compliance or whatever. If there is really obstruction, the patient is destined to come down and refuse CPAP. If the patient is compliant, I ask them to carry on. But maybe in the long run, we assess the data and the compliance data, the pressure, and already we have done the DICE. So it will be easier for us to explain them, boss, we have already seen these are the dynamic blocks, and that is why you're non-compliance. So plan for the dynamic surgery later date.
So at this point, we can give a take-home message for our audience that if there is a static obstruction, do a PSG, get on to the surgical management outscores the PAP therapy. And if there is a dynamic obstruction, get us a PAP trial. And only if the patient fails, then you discuss about the surgery. And dynamic obstruction, DICE or any other dynamic MRI is must before the surgical management, right? Can we give this and go ahead with a little complicated question just to follow?
Sagar.
Just one
Sagar.
small point,
Yeah.
if I may.
Yeah, who is speaking now? Because
Simab.
Simab.
So just to the point what Dipankar said, that if he's happy with the CPAP, I will still give him that option and say that there is a choice for you to get off CPAP. If you would like that, then we go ahead. Just because he's CPAP compliant, I will not keep away the options of surgery from him. Let him choose. I will give him that option. There is an option to get off the CPAP.
Okay. Yeah.
So Sagar.
Yeah, Sandeep.
I would go a bit further, you know. A lot of young patients are coming to me who are sleep apneics, you know. We are always talking about that we should say that, you know, there is enough evidence that CPAP does not help with cardiovascular comorbidities. Surgery should be first choice. Now, a patient comes to me and says that I will not use CPAP. Doc, I will not use come what may. You have to do something else. Then, is there any point of, you know, asking the patient to go for a CPAP trial? I'm raising this question. I do not give.
So-
I do not give CPAP. So you all
If
about
the patient has
documentation. We are
failed a
talking
CPAP
about.
trial,
We will
we are
document
talking-
it. We will document it. He
Yeah.
is not ready.
So you
We have to
document
document
it.
it that patient has refused CPAP.
Yes.
Yes,
Why are
exactly.
we forcing him for a CPAP trial when the patient doesn't want it all?
No, so the only idea, sir, I'm sorry, I'm taking the panel away, but the only idea of giving a CPAP trial is to look at the reversibility of the symptoms. The symptoms which are going to reverse after a CPAP trial are only going to reverse after surgery. If the patient's EDS doesn't
Exactly.
improve with a CPAP trial, his EDS is not going to improve with surgery. So to give in that, but there will be
Is
patients
there,
who will refuse, I agree, or who can't use it and all. But the thought process is it will give an awareness. CPAP, see, whatever intervention that we are going to do, patient may require CPAP at a later stage also. I mean, the thing is
sir,
CPAP,
if the patient is already having static obstruction
yes.
and we are still giving a CPAP trial,
Absolutely, that's what I
how
was
will the
saying.
EDS go away? How
The
will the
nose is
EDS
full
go
of
away?
polyps. You will
No,
not
so
do a sleep study.
so
And
if the patient is not able to use CPAP, that's a different story.
Yes,
Point.
yes. I meant for that only. I was
Yeah.
trying to
If he is not able to use or not willing to use, with or without polyps, with or without static obstructions, we have to go ahead with our plan, but it has to be documented. We cannot
Yes,
forego
yes.
it.
We documented. That's fine. That's fine.
That's all. That's all.
So
Yeah.
That's
one,
all. Yeah.
so
So
I
that
will,
brings to this questions actually. What if there is a combination of static and dynamic obstruction? There are going to be a subset of patients who are going to have a combination of static obstruction in combination with dynamic obstruction. What are you going to do? How are you going to proceed with them? Are we supposed to do a sleep study before or after correction of the static obstruction? Or are we going to give a CPAP trial before correcting the static obstruction and again after correcting the static obstruction? How are you going to do, Srinivas?
so that's exactly what we discussed earlier, that
Yes.
you need to do quantification of disease. Quantification of disease burden has to be done if he's come to you primarily with a sleep apnea sort of a concern, whether it is snoring or excessive daytime sleepiness or whatever the symptoms are. Even if they don't come to you with the classical symptoms, and if you seem to be sensitizing them and they seem to be sort of going along with what you're saying, it becomes imperative, whether it's a child or an adult, to quantify, because we are trying to understand physiology, because OSA is just not about anatomy. And also this brings us to the fact that even for a CPAP, right, everybody knows that the first 1 month of CPAP therapy is going to make it or break it for these individuals. So in the 1 month, if our optimization in terms of clearing the static obstruction is not done properly, the patient is going to abandon the gold standard therapy forever. So again, the onus is on us to evaluate the patients, to rule out static obstructions, to make see, supposing you have a 70-year-old man with very bad septal deviation, there was no need for him to go for a procedure before. Now he needs to use a CPAP because he's got arrhythmia, right? So you need to opt, and if you don't address it, his arrhythmia is not going to come under control, because sleep apnea seems to be driving that particular problem. So again, bringing us to the fact that one, quantification is important. The need for treatment and urgency for treatment only comes from the end of at the end of sleep study. And number two, it is upon us to make the CPAP compliant to the patient by clearing the static obstructions.
Vikas, would you agree with the above, or do you have any different take? Or would you like to give a take-home message like, if there is a static obstruction in combination with dynamic obstruction, this is how I'm going to do. I'll clear the static obstruction, then do a sleep study, then do a CPAP trial, and then address the dynamic obstruction? Or is there any other protocol that you would like to follow?
So Kishore, Sagar, this is the most practical scenario. Have you ever seen a severe sleep apneic with only static obstruction, only blockage of the nose? No, it's always, almost always a combination. Nose is always involved with either palate, base tongue, or whatever. So, like Srinivas said, that it is our duty. We should not feel shy of, no, if we have suggested a surgery, it's only to make money. Let's come out of that. We can make money by playing share market better. So if we are here to help the patient. If, like, I have operated in the last 3 months, at least 6 or 7 70+ people only for the nose. They have come for sleep apnea. I have done a nasal surgery. I put them on CPAP because I do not want to do a pharyngeal surgery at that 74, 75 years of age. But I have operated on their noses, and one of them is my relatives. He stays in Goregaon. Like, I asked him to get operated around 10 years back. He didn't do it. Now at the age of 74, I had to do his septal surgery. So this brings to the point that you have to remove important static obstruction. I'm not saying that a little deviated septum, you go jump and operate. So best is to do removal of the static obstruction, then do the sleep study. If required, sleep endoscopy, give the CPAP trial. That is the best. I advocate it to each and every of my patient that why don't you do the nose surgery first? I do the CT scan on first visit in my clinic itself. If the nose is grossly deviated, I said, no point doing, your sleep study is going to show more problems than actually is there because of the pharynx. If I put you onto CPAP, you're not going to tolerate it. So nose, you have to get operated today, tomorrow, or day after tomorrow. So do it today. That is the best. If the patient says, why don't you just evaluate and finish it at one time? And if I believe that the tongue base is not looking large on the CT scan, then I do sleep study and sleep endoscopy as the primary procedure. Then let the patient with the nasal decongestion, put the patient on Otrivin nose drop and then give CPAP trial, so that at least he can tolerate the CPAP. Otherwise, it will be only a lawyer's job to put him on a CPAP with a blocked nose. So I say that, all right, you simulate your nose surgery with Otrivin nose drop, you take a CPAP trial. And if you're doing well on CPAP, I know that everything what was said earlier is true. So this is how my...
Thank you, Vikas. So just a second. Yeah, who is that? Seema?
Seema, yeah.
Seema,
See, there
your
are two
camera
ways to
goes off.
look
That's
at.
why.
No, sorry, I'm sorry about that. There are two ways to look at this question that you've put across. There's a lot to do with the age, like all the speakers have been talking about. There's a lot to do with the age and the aim of the surgery. Now, we as OSA people, we know that if you have a static and dynamic, if you follow the concept of two minors, one major, there's no reason why you can't do a static and a dynamic together in one stage. So if you've got a nose and you've got a palate, you can address it in one stage. So the point is, a lot depends on your age factor and what are you doing the first surgery for. If, like what Vikas said, Srinivas and Vikas both said that if you want to clear just the nose for CPAP compliance, that's a different matter. Then you repeat a sleep study again and do it again. If not, you can do it in the first stage.
Okay.
Sagar.
Yeah, Sandeep.
Sagar. See, we are talking about static obstruction and dynamic obstructions. I'll come back to what Kishore just said. If we don't know that the patient has OSA, why are we talking about static and dynamic obstructions? These come into picture only when we are talking about obstructive sleep apnea. And we will know about obstructive sleep apnea only when we do a sleep study.
Exactly.
So the sleep study is a must. After that, we can see whether you want to do static and dynamic at the same time or at different times. That's a
no, getting a sleep study,
or
there is no argument.
Lot of time, once the patient, like it has been established that the patient has obstructive sleep apnea. So I give a choice, like the patient can undergo a DICE along with septoplasty. So the static part is over, the DICE is done.
Perfect. That's how I do it also.
The patient can choose between CPAP and surgery, the pharyngeal surgery.
As soon as you are done with the nose part.
Yes.
That is the exact protocol that we follow also.
Totally
We do the nose part along with the drug-induced sleep endoscopy. But not to deviate here, there is one important question that I have. Dipankar, can you answer this? I think there is a good consensus as of now about the nose part, which is easier to say. But what if the patient is having an enlarged tonsil? If it is an enlarged tonsil, even though it is a static obstruction, if there's a concomitant dynamic obstruction, would you try to address the tonsils alone in the first stage, or would you combine it with the palatal surgery? Because if you remove the tonsil, which is your friend in treating your palatal surgery, it is going to be a little tricky. So would you give some clarity on the enlarged tonsil part? I'm talking about the adults, not about the pediatrics.
Yeah. For the adults, if the tonsils are quite enlarged, and if the patient has turned up to me for the sleep apnea, we are talking about sleep apnea here. We are not dealing here with the tonsillitis patient.
No.
The patient sitting right in front of me is basically a proven, I must say, PhD proven OSA.
Yes.
So in a PhD proven OSA with big tonsils, I will do DICE and do the tonsil and the palate procedure clubbed together in a single sitting.
Okay, perfect. So I think that is very loud and clear that even if there is a static obstruction in the form of enlarged tonsil, without doing a DICE, please do not just remove the tonsils out, because you may have to combine it with your palatal procedure in future. So we will go ahead with the next question now. Yeah, these are the take-home message. So we will go ahead with the next question now. I think this is a very good question for both Srinivas. Srinivas, are you there?
Yes, yes, I'm here.
Yeah. Srinivas, I think we come across this classical structure that is a lovely structure that is described by our friend Vikas here. I think we do come across many of the times this big prominent salpingopharyngeal folds.
Correct.
Yeah. So if there is a prominent salpingopharyngeal fold, would you just have any procedure in the form of palatal procedure that can address that? Or do you need to address it separately in form of either channeling or any other technique to address that?
So it basically again depends on how you understand the dice, right?
Yeah.
You need to look at where the contact point of those the salpingopharyngeal. If it is higher up, much above the velum, like you're showing here beautifully,
Yeah.
that needs to be addressed individually.
Separately. Individually. Yeah.
Now, if it is in the lower down at the part of the velum, all right?
Right here.
Yes, around that area, because salpingopharyngeus extends down as the palatopharyngeus going down up to the thyroid ala, addressing the palatopharyngeus will also take care of that particular part of the salpingopharyngeal fold.
Very, very nicely
Depends on
said.
how you evaluate it.
Very, very nicely said, Srinivas. So, because the question to you again, this kind of salpingopharyngeal fold, how do you choose between playing aggressive versus semi-aggressive? Would you go ahead first with the channeling? And if it is in spite of that persisting, then you would go for some aggressive technique that I'm going to show you again shortly?
Yeah.
Or would you directly go ahead with, what is your choice?
Yeah, so this is a very critical area of the nasopharynx. If you are aggressive on that, you can lead to a very bad nasopharyngeal stenosis. So channeling is the preferred procedure in most of the cases, because by doing that, you always preserve the mucosa and you will not most likely create a complication. And you must not add it with adenoidectomy. When you're performing adenoidectomy and in the lower part, you have done an aggressive procedure like this, what you're showing now. Obviously, here you're not doing a palate procedure, you're not doing the adenoids. So the only raw area you are creating is on the salpingopharyngeal fold. But if you are actually doing an adenoidectomy, you're doing a palatal surgery, and you're also very aggressive on the salpingopharyngeal fold, then you may land up with a very bad nasopharyngeal stenosis.
But I have seen you showing this kind of procedure before.
Yes.
Like, how safe is this to do it if alone you are doing it along with the nasal surgery? Is it safer? Is there
the
any
nasal
worry
surgery-
about the eustachian tube injury? Is there any complication leading to scarring and patient developing any otitis media with diffusion or patellus eustachian tube or any other problem like that?
Correct. So if you are only taking care of the lymphoid tissue on which are submucosal, then there's absolutely no problem, because there will be no issues of scarring and eustachian tube. If you are going into the substance of the salpingopharyngeal muscle, then you have to be careful. And you have to be really very careful about creating a raw area 360. So if you're doing, even if you're doing a procedure, you should leave a strip of mucosa on each side, not connecting with the soft palate and the posterior pharyngeal wall, right? If you leave a bit of mucosa and do some aggressive procedure, it's fine. But if you do not leave the mucosa and go 360, you are doomed.
And this procedure works well for the prominent salpingopharyngeal fold, or will it come back again? That is the next question.
So if you are only channeling, obviously it will not be for life. I have completely, you are only coagulating. I have actually completely removed huge salpingopharyngeal folds, making sure that the posterior pharyngeal wall and the soft palate is not touched at the same time. So there's absolutely no problem as long as you understand the surgical principles.
Okay. Thank you.
Salpingopharyngeal muscle, if you remove, there'll be absolutely no problem with the function because it's already hypertrophied. So you have removed only a part of it, not a problem. Levator palatii and tensor palatii will keep on opening the eustachian tubes, not an issue.
Now the question is to Dipankar. This is a 48-year-old male with moderate OSA, failed CPAP. Mouth opening is only 3 fingers. Anesthetist had a slightly difficult intubation. Patient is having a bulky uvula and high tongue base, crowded anatomy, planned for a palatal procedure, but not able to insert the blade adequately to have a good access to the oropharynx. How would you proceed?
So this is indeed a difficult scenario.
But this surgery is anyway going to fail, so don't operate. Sorry.
Exactly. So definitely, failed CPAP and 3 fingers anesthesia, difficult intubation. I think just by thorough discussion, maybe I'll do a CT or X-ray cephalogram, discuss with the patient, and will not try to operate. And we'll try a CPAP again if possible with the different settings and try to make him compliant. We have to understand, I think we have to understand why the CPAP failed. In a case of moderate OSA, in a 48-year male patient, there is no point of failing of CPAP. So we have to understand why the CPAP failed. Is it because of the machine settings? Is it because of the some kind of leak? Why the patient failure means what to the patient? He is not able to tolerate because of claustrophobia. I think I will engage my technologist and try to make him compliant to CPAP.
Okay. Srinivas, I see
Sagar.
that you have raised the finger.
Yeah. Okay.
Simab, you want to take
No,
it?
go ahead, Srinivas. I'll take it after you.
Basically, this guy is, for me, a skeletal patient.
Absolutely.
He's not a soft tissue patient at all. For me, the counseling would be completely different. I would get a CBCT done. I would get an OPG done. I would do an airway analysis. And I would actually counsel him
For a maxillomandibular.
basically, yeah, for an MMA or a dome, based on what kind of, whether it's a transverse deficiency or an anteroposterior deficiency.
Exactly. That's why I told you
Yeah.
have to assess
Sagar.
CT or
Yeah.
cephalogram. Yeah.
No, the details don't tell us much with regards to what is the reason for the mouth opening being only 3 fingers, right? So if there is something that is correctable there by condylectomies and stuff like that, then it just becomes a second stage for us to get into. And for whatever other reason, like sometimes we speak, of course, this is maybe purely hypothetical. And if you really want to do something for this guy, at least in terms of tonsils and stuff, maybe a tracheostomy with proper counseling, very, very proper counseling, that you're going to do it just for that 1 week's time till he finishes the surgery, and then you get out of it and then remove the tracheostomy and go ahead. That is an option that should be spoken about.
Sagar,
Yeah, Sandeep.
I think see, we are all assuming things because some very important details are missing. Like as Kishore has already said, that seems to be a skeletal patient than a soft tissue patient. So what about the maxilla, retrognathia, mandible? And another thing which we should see is failed CPAP. You're talking about moderate OSA. What is the BMI of the patient?
This patient's BMI was 32.
Yeah, so it's okay, like not very.
Yeah.
So
He's not that obese.
this patient, yeah. So I just wanted to add, like, we need to have full, like, most probably it will be something to do with his maxilla or mandible. Maybe they are retrognathic or hypoplastic.
There is no retrognathia and the maxilla looks fine. Would you
So
still go ahead?
Then we're not thinking of maxillomandibular.
Why should there be 3 fingers?
Exactly. That's what I was trying to understand.
If the tongue is so large, high tongue base, then your
Right.
surgery is anyway going to fail.
Yeah.
Palatal surgery is going to fail if the tongue is so large that you cannot intubate. You cannot
So
see.
definitely, even without a obvious external skeletal deformity,
Can still
still
happen.
there are a set of patients who would
Right.
suit for maxillomandibular advancement. And these are the patients definitely need to get a dental colleague's opinion and then do the needful accordingly.
This guy will be our Friedman's tongue stage 3, right?
Stage
Three.
3.
Your
Yeah.
success of
Yes,
soft tissue surgery is very poor.
So
So
just a
let's
couple
move
of
on to the
points.
next.
Just a couple of points, Dr. Sagar. One is we can evaluate the role of improving the nasal passage in terms of improving CPAP compliance. That is one. Only my hitch against any extensive skeletal procedure would be he's 48. Typically, the ideal candidate for any extensive skeletal procedure would be under the age of 40. So 48 would be kind of like, a tricky scenario where we are thinking about some extensive skeletal procedure. So these are the only 2 points that I would like to highlight.
So let's move on to the next scenario. Again, we'll start with Dipankar. Dipankar,
Yeah.
this is like immediate post-op. Have you come across? I think you have been doing various types of procedure like Zeta or relocation or expansion and ESP with AP. So have you come across with the suture giving off or let's say the flap falling off? If so, what is the trick to avoid it and how are you going to tell the younger colleagues to face that situation?
Yeah, I have faced this. Suture giving away is actually a very common thing, but the main important thing to avoid this is uh, don't give sutures, don't put sutures too much tightly.
Yeah,
Allow
perfect.
keep the space for edema, because in the postoperative period there will be destined to be some swelling and the edema. If we put the initial sutures too tight, it is destined to basically give away. So give the sutures just optimally lightly, so that during the edema it just gets snugly fit. So not to put the suture too much tightly is the first point. Second thing is, if we give, suppose allow in some cases, patient doesn't follow postoperative protocol and particularly the diet protocol very judiciously, and if they start taking some kind of too much of rough, solid food, some sharp objects, then there is a chance of suture giveaway. That is basically our prerogative to make them understand exactly what kind of soft or semi-solid food they need to take for initial 10 or 15 days. Next is the suture pattern, because I do barb also. In barb suture, if not placed, if the knots are not, the point of taking up and the point of the next entry of the suture is not exactly synchronous, there is always a chance the sutures remain exposed, and there is a long-term chance of giving away of these sutures, and that will be a disaster, because in barb, if any point of time at one point giveaway means ultimately the whole sutures comes away, kind of thing. So it is extremely important. And but by shifting from basically the conventional Vicryl to the PDS, I have faced the lesser chance of giveaway of the sutures, but because at the first layer, the deeper layer, the PDS sutures anchors very well, and it usually don't give away.
Okay, thank you. Srinivas, a question to you. If there is a situation where there is a kind of a flap giving away or fall or whatever the technique you are using, is there any situation wherein you had to go back and resuture, or usually it is not that scenario?
It really doesn't come to that you have to take the patient back to the OR. Sometimes even just unless the zeta and your entire flap sort of falls off,
That
I
is the
don't
only
think you
place.
need to go back to the theater. You can probably just trim that margin and then probably take care of that scenario. It's very seldom that
Very
you have to
seldom.
take the
Yeah.
patient
It
to
has
the
never
OR.
happened to me at least, but there is something like this. The mucosal layer, at least there will be slight necrosis kind of thing because of the blood supply and tight suturing in my earlier period. But rest of the things, I never had any situation where we had to take him back to the OT. No, but this is a very this is a very commonly reported thing that in the Bob suture, this kind of Bob suture sticks out. Do you all get this kind of problem, or is it only the improper technique?
No. So I would like to add, Sagar, that when you use barbed suture,
Yeah.
any part of it comes out. It's a very hard suture, so immediately
Yes.
patient gets a lot of
Pricking
pain,
them.
pricking sensation. So immediately you have to remove it. And if you remove it, do not go inside and remove it. Somebody else removes it. He leaves a small stump. Again, it hurts. And
Yeah.
anyway, you barbed it, cut at one place, then the whole suture is gone. So with barbed, the technique is much more important than with Vicryl.
Is it like that always? If you cut one place, the entire thing goes away?
No,
I
you
mean,
not
the work,
necessarily.
No,
it will remain inside, but it will not do its work because now it's divided. It's not individual
So,
suture. It's one barb which has gone everywhere.
No, it's the bristles that are
Sagar,
anchoring the muscle that's actually holding it together.
so
So,
what you can do if you're just getting a point of it jutting out, you can actually pull it up and go deeper into the tissue and cut deeper so that whatever little part that is
Correct.
jutting out just gets removed externally and the rest of the suture remains in.
Agreed.
And as far as
but-
your flap thing, Sagar,
Yeah.
by and large, generally, most of these flap failures, if at all, I mean, and it's never a complete failure of the flap, but most of them generally tend to heal well with secondary intention. And you've got to just make sure that the patient is well assured that, okay, this is just a speed breaker to healing, and this is going to probably take another 2-3 weeks extra. And please maintain hygiene much more carefully during this secondary healing time.
So
Thank you.
just a
Thank you.
point, just a
Yeah,
point.
Rahul.
It is, I feel the scarring that we create in the scarring vector that we create in the palate is equally important.
Yes.
Yes, nobody wants a flap to fail, but even if the flap is failed, you have created a scarring vector where the flap will move or the palate will move more anteriorly and laterally regardless. And you'll still get the outcome. And after a few weeks, if you're excising the sutures and everything, I think the scarring will take care of it. So unless and until there is some other complication, if there is an extrusion of a suture, then I would not worry because I feel I have scarred the palate enough to take care of my outcomes, so to say.
Srinivas, going back to the same point that we were discussing, because the barb has multiple bristles all around, just by cutting in between, I'm just asking it aloud, just by cutting one place, will the entire tension go away, or because it is going to hold in multiple points, still it will work well?
it will, see, the answer there itself is if you actually try to pull while you're doing itself, if you try to reverse pull the barb, it will not come
Yes.
because it is already engaged in the muscle, right? So if you just cut it there, the bristles, especially when you're using Quail or V-Lock, the bristles are much better when compared to the Stratafix.
Okay.
Yeah, so in such cases, it doesn't come out.
Okay. Let's go on to the next question. Rahul, in your palatal surgeries, would you come across with the post-op edema, or doing the surgery itself, have you come across with the edema in the palate, which has caused you some discomfort?
I mean, during the surgery, less likely.
Yeah.
Post-operatively, definitely. And like Dr. Dipankar pointed out, not to keep the sutures too tight. And what I've started doing is I've started giving some amount of dexamethasone to patients in the preoperative, like, in the intraoperative setting. And also sometimes for typically 24 to 48 hours in the post-op period. So some amount of edema and I feel pain gets taken care of. I don't like to give it for very long periods of time because it may impede with the healing. But that's what I do. But essentially, idea is, yes, edema will definitely come in the post-operative setting. Intra-op, I mean, I feel, I have not faced that challenge, I would say. Post-operative, 100% there will be some edema. Snoring may actually get worse for the patient for the first few days. So it's very important to counsel the patient that all that we are doing, the benefit the patient will see only after 2 weeks. or so. May not.
Dipankar or Sandeep, have you come across edema? Because you do relocation also, Sandeep.
Yes, yes, definitely.
Yeah. Edema
On
is very
table.
common. Edema is
Not
common.
on table, sometimes of
Postoperative.
the uvula. Sometimes of the uvula,
And as Rahul
but
said,
not as the palate.
my anesthesiologist routinely used a steroid. We give dexamethasone, same.
So
Yeah.
intraoperative swelling is more because of the
Lymphatic obstruction, right?
Yeah.
Because of your
So-
tight.
More because the tissue handling of the
needle hitting a vessel and there's a bleeding inside the soft palate. It's pretty common. I mean, you hit a small vessel, there'll be some bleeding and little swelling. Obviously, how edema can happen so fast within half an hour. But intraoperatively, if you have it, generally it is because of small hematoma.
Or maybe sometimes, by mistake, your sucker has pulled the uvula, like your
uvula. Uvula is the most commonly edematous.
Yeah. Yeah, let's move on to the next question. I think treatment of edema is comparatively an easy headache than the disease itself. Now let's go on to the next one. Is there any way, while doing the surgery itself, is there any way to predict whether your surgery that you are doing it is actually going to help the patient? Is it adequate or not? How aggressive have to be done? Do we need to do even more aggressive pull? Is it enough or not? Or do we need to loosen it down? If you're doing a barb, is it actually reversible to get the suture back? Is it possible or not? What are the tips and tricks? Can you guys tell us? I will start with Vikas.
So first of all, by the time you have anesthetized the patient, it's too late to predict whether the procedure will be successful or not. You have to take this decision back in the OP while counseling the patient.
No, I'm not talking about the selection of the procedure.
Right.
While doing the procedure, is your pull adequate? For example, let's say your palatopharyngeus going to the pterygomandibular raphe. Is it adequately enough to pull laterally? Is it adequate or not? Or do we need to put another suture or not?
So I think the maximum you should get in every case, right? To me, whatever maximum I can do on the table, I'll do it. Obviously, if the tension is very high, obviously, I'll keep the sutures loose and I'll not make it so tight that it will cut through. But apart from that, the distance between the pterygomandibular raphe and the soft palate, I know from beforehand. If somebody has a narrow maxilla, I'll possibly not operate on that patient. If the maxilla is wide enough, then I know that I can pull it laterally quite a bit. And I put a suspension bridge to keep it more anteriorly. We pull it laterally. I think what you're asking beyond, you do the maximum, as simple as that.
Yeah.
Let others.
Srinivas?
Yeah.
This is what we used to do before, right?
Yeah.
Pulling the uvula forward, getting the flaps this side, that side, assuming that we've done an amazing job in the intra-op period. But that is not what gives you the final treatment. As Vikas said, once the patient is anesthetized, you're too late in judging anything. See, the success for you comes by the scar vector, finally. What are we doing? We are trying to create a scar vector in an anterolateral. No matter what you do in the intraoperative, you need to be technically sound. You need to get the scar vectors which are going to be your judges at the end of the procedure, which will not happen immediate post-op period. Your flaps might give away. Your blobs can extrude. Whatever you can do, you're basing on three main things. You are going to spare mucosa, you are going to make flaps, and you're going to respect muscle and create scar vectors. That is the ultimate so sound technique, respecting mucosa, and creating of the scar vectors are what will finally determine the outcome of this patient.
Dipankar, you have any trick or somebody?
Earlier, we used to put suctions and reverse the scopes up and see. No, that is archaic.
Yeah, Sagar. So, in agreement with everything that's being said, but there is nothing beyond the pterygomandibular raphe. That's what you're going to get. But to answer your part about whether you think your suture is too tight or it can be tightened more, you can put in a flexible endoscope through the nose while you are pulling that suture. And of course, making
Exactly.
sure that your suture does not become so tight that it's going to give way. But if
Yes.
you put in a scope through the nose and you're watching on the monitor while you're pulling the suture, you'll
Yeah.
get a pretty good idea about how much you can pull further. And that's
I would
something
agree
that
with
I do
you.
sometimes. I
Yeah.
do that sometimes. Yeah.
But the neck is extended. That is not natural anatomy.
No, I agree. I totally agree.
So
I'm just
no
saying.
matter what you do it in that kind of an assessment is not a true assessment.
And my
Because
point is,
patient is
you will
not
anyway
going
do
to
the
keep his
maximum,
neck
na?
extended.
My point
No,
is,
because
you
if
anyway do
you are doing
maximum.
maximum, there is a chance that the patient
See,
may get a BPI, and you don't want to create such a big opening where the patient will get a BPI, you know?
No, Srinivas, see, it's not about the neck extension. This is not about seeing the lateral part. It's about seeing how much tension you can still give on the suture.
Yes.
Is it possible? I'm not saying that we are predicting the opening of the airway by looking at that visual. I'm talking about how much still further pull you can give onto that suture.
Yeah.
Because it's
Let's
already
go on to the
up.
next question.
Yeah, fine.
There
Go
is a
ahead.
patient who had a modified UP3 done, 45-year-old, status post palatal surgery done elsewhere. Initially, he was doing well, but then he started developing snoring, witnessed apnea, and he came up with the repeat sleep study with these parameters. And this is how intraorally you can see that there is a slight Gothic arch in formation. You can see that here.
Yeah.
So, and you can see this palatopharyngeus muscle still here. And this is kind of a cylindrical opening here. So, how would you proceed in these cases? Would you, what would be your take? Because.
So first of all, I don't think this Gothic arch is the reason of failure. See, this little bit of anterior pillar be looking this way or that way doesn't matter. The opening, we'll do a dice and see
It's
what
not
which
anterior
part.
pillar, it's the posterior pillar. Yeah.
Correct. So posterior pillar is the problem. So anterior pillar Gothic arch, what you're saying is absolutely a normal thing to look at.
Yeah, it's the
That
posterior
means
pillar what you're seeing here.
absolutely. So the lateral pull possibly is not adequate. The posterior pillar is still collapsing. So we'll have to do the dice and see what is happening. And if required something, do something for the posterior.
How would you, Dipankar, you do a dice and still there is a collapse like this.
First of all,
Yeah.
first of all, if a postoperative patient previously surgery done like this, and there is a recurrence of symptom, I would first initially assess whether he has gained his weight or not, because the weight gain is one of the commonest factors which results in delayed failure of any kind of best possible surgery done by any previous surgeons or by myself even. So I will look at his BMI, any change in the BMI. Number two, exactly the selection of the procedure, faulty selection of procedure, wrong identification of the site of block, and last but not the least, faulty technique. Suppose failure in my hand, I couldn't do the procedure correctly. So I do a repeat dice and definitely try to understand exactly what are the residual or recurrent new kind of block is there. So residual block or recurrent block, this thought process has to be there.
In case you find the kind of dice that I had shown you, what would be the procedure of choice that you would do in a revision patient? There is no.
Would you repeat it, please, once more?
We just go to the point of interest.
I will do.
Yeah.
I will prefer Zeta in a failed previously done palatoplasty.
Okay. Is there a role for Barb?
Yeah, definitely there is a role of Barb, but I will, in my hand, I will prefer a Zeta.
Zeta. Okay. I think we have already seen a wonderful wonderful procedure by Dr. Ahmed Hassan. Because of want of time, we'll proceed with the next question. immediate post-op experiences like globus sensation, change in voice, velopharyngeal incompetence. I think because of want of time, I would just ask each one question to one of you, and we'll proceed with the further. Seema, can you answer that? Seema, are you there?
Sorry, Sagar. Sorry, just tell me that again, please.
So is
Sorry.
the patient, how often do you get a patient with the postoperative velopharyngeal incompetence in your practice? If so, is it temporary, permanent? If it is
So by
temporary,
Yeah, by and
what
large, they
advice
are
you
very
would give?
temporary. By and large, they're very temporary. It's not a very uncommon finding to have post-palatoplasties, especially if you miss the dimple and you've not kept into that Lakshman Rekha part. But it's by and large pretty temporary. You just have to explain to the patients and make sure that they realize that it will go away over a period of time. But like I said, this is all subject to you not having crossed that Lakshman Rekha. So
Perfect.
also the issues with the voice change, because that's purely again temporary related issues. And similarly, the same thing. I mean, these are things that are going to happen. There are a lot of patients very commonly, but very transient in their behavior or in their appearance.
Let's go on to the next one. Sandeep, for a tongue-based surgery, I think we all follow based on the type of the tongue-based, whether it is a lymphoid tongue-based, what is the collapse, whether it is somebody is talking. Yeah. So this is the patient with this kind of tongue base in a dice, like a dumbbell. It is collapsing like this.
Yes.
How are you going to address this?
Midline.
See, so usually when we do tongue-based surgeries, we try to be in the midline,
Yeah, but
Maybe
this
one
is
cen-
kind
1
of
centimeter
infolding like this from the lateral wall.
Yeah. So going for a tongue-based surgery in this case, because the peripheral part is collapsing on itself, would be very dicey. You can end up injuring the lingual arteries.
Okay.
So that's one
Anyone
thing.
in the panel want to
Maybe
answer
you
this
can try
question?
a minimally invasive surgery, or once we have an hypoglossal nerve.
Srinivas, Vikas,
I
Deepak.
think a channeling here would really make a lot of sense. You could try the channeling here.
Yeah, that is what I meant with minimally.
Yeah, absolutely.
So,
This
if I
is
may,
So to
if I
me,
may,
sorry,
okay.
go
Go
ahead.
ahead. Go ahead.
Rahul.
Whoever is speaking.
Rahul?
yeah,
Rahul?
okay.
Go ahead.
So, I mean, for me, someone with a very high sort of a tongue base is perhaps a sign of a relative mandibular deficiency. So that is something that I would like to evaluate perhaps earlier, because it's like a tongue which is trying to adjust in a smaller mandible. And so the best hypopharyngeal surgery or a tongue-based surgery would be addressing that if there is a retrognathia. So an MMA would be the best solution if you are looking for a surgical outcome. Otherwise, a non-surgical outcome or a non-surgical intervention would be a combination of myofunctional therapy with CPAP. That along with addressing the obstructions much higher up in the nose and the velopharynx. So that is a point I want to make. If you're seeing a high tongue base, a very bad tongue base, perhaps without lingual tonsils being hypertrophied, you should look for skeletal deficiencies as a cause.
Vikas,
I think
I
when you
don't-
put up
Vikas,
this
you are seeing
question,
Yeah.
a little bit of more lymphoid tissue there.
No,
Would
no,
you
no,
be
no, but
tempted to do any
no, but see that
exact?
not only is the tongue base collapsing like this, even the posterior hypopharyngeal wall is also collapsing
Yes.
like this. So what are
Exactly.
we going to do about it? This is not a surgical patient, not a soft tissue surgery patient. Either CPAP or what Rahul said, MMA. is the patient.
See,
What about this kind of a tongue base? Srinivas?
Yeah, see, this is a typical anteroposterior, what we call in word classification as a T2AP, right?
Yeah.
So
Yeah.
this kind of a T2AP patient, you can go in from giving him a mandibular advancing device if he's not a mouth breather. First of all, these patients, you need to check if this patient is a mouth breather. And while doing DICE is an excellent opportunity for us to actually close the mouth and see if the tongue is actually repositioning itself, right? Point number one. Point number two, if the patient wants to be conservative, you can offer a mandibular advancing device. These patients do very well with mandibular advancing device. And 3, if that is not the case, you can possibly think of doing any kind of a invasive tongue procedure, whether it's midline glossectomy or a Coblemo or a Robocob or any of those.
Okay. So this is the next question. I would ask Sandeep your opinion. There is a patient with the dice showing this kind of a finding,
Yeah, that
like
has to be a primary
trapdoor,
epiglottic collapse.
primary epiglottic collapse, I would say.
We need to confirm it. If it actually is, we can use a nasopharyngeal airway and then put a scope. And if it is still collapsing, maybe a suprahead epiglotectomy or a epiglottopexy can be tried in this patient.
Okay.
You can do a positional thing also, and if it is still on the lateral position, it is collapsing, then we can do this surgical part.
Yeah.
For a primary
There is
epiglottic.
another patient who is having a velopharyngeal collapse as well as the epiglottic collapse, but the epiglottic collapse is like an infolding type, not the trapdoor type. This patient, I think we are doing the interventional dice by passing the nasopharyngeal airway. And by doing so, we are bypassing the palatal obstruction and we are looking at the epiglottic collapse. And in spite of bypassing, you still are able to see that there is an infolding type of collapse. And we are trying to change the position of this patient. And in spite of the changing the position, still there is this epiglottic collapse. So, Srinivas, if you are having this kind of a patient, what is the type of the procedure you will do? And what is the...
What's the?
You just tell me what is your
Okay.
take on,
So
take on this?
this patient basically would require a suprahead epiglotectomy. In my hands, that would work best in transverse collapse.
Yeah. Is just doing a suprahead epiglottomy enough? Or would you do like laryngomalacia surgery, like only trimming off the lateral part of the epiglottis?
So in an
And creating a raw surface, and as Vikas would do, like doing a median glossoepiglottic ligament coablation only to address the remaining part after resecting the lateral part.
For me, AP collapse, you can actually try the higher epiglottopexy, but this kind of a lateral collapse, 100%, I would want to be safe. And in my hands, I would do a suprahead epiglottic.
Yeah.
No, even I would agree.
I second that. I fully agree to that.
I also agree with Kishore. In this
Yeah.
kind of things, just a sticking thing will not work.
Will not work. Yeah.
I have tried to preserve some epiglottises, but did not succeed.
The one that I have shown, I think it needs a suprahead, right?
Yes.
So the point we wanted to say about the interventional dice is the take-home messages, like you want to bypass the velopharynx and see if the epiglottic collapse is still persisting, right? Is that the message?
Correct.
And if it is
Yes.
still persisting, you would address it separately. But there are instances wherein you would have a patient with a dice in which wherein without airway, there is no epiglottic collapse. But as soon as you insert the airway, you are getting an epiglottic collapse. Have you come across patients? I have come across at least 3-4 patients like that.
Well, for me, I would look at the BIS score.
Yeah, I have
taken the patient too low?
Yeah, no, the BIS score is 70. I think it's shown here also while doing it. 70. And during the interventional days also, the BIS score was 70. Do you get the patients like that?
Well, to me, I have not come across such patients like that. It's basically
Because have you-
that there is a much, see, if there is a problem higher up, and you have sort of annulled that higher up, the most compliant thing would next fall off. So which seems to be the epiglottis in this case.
Yeah.
I
The reason
I
is,
had I had one patient, but he was a very young chap, thin, lean. He had not exactly the similar thing, but quite a lot. Like his palate was collapsing as well as he was having primary epiglottic collapse. So since he was a young patient, and it's very difficult to
this is another patient.
be
I'm
sure
having
that
like
it is
3 or 4
so I
patients.
did
Yeah.
the palate as well as the supraorchid epiglottictomy in this
So
patient.
were the proximal obstructions and the distal obstructions assessed at the same base?
Yes.
Yeah,
Yeah.
Well,
Okay. Let's go on to the next question. I think the final few questions, and then we will round up. Difficulty in counseling. I think this is a very pertinent question, because the results after 3 years, will it vary? And if so, why? And how to counsel the reasons to the patients later on after 4 years, the results might vary. Seema, would you answer it?
Yeah, so results will vary, as in we are doing a surgery for his obstruction. There are also a lot of neuromuscular incoordinations that we have to insist and we have to counsel them right in the beginning, that there could be factors where you will have maybe a recurrence of weight, maybe as your age grows in. So you can't just have one procedure done to you at the age of 28, give you results till you're 55. There are going to be changes in the human body. There are going to be hormonal changes. There are going to be weight changes. So I think this is a very important part of the counseling. But at the same time, it has to be done very, very carefully to not put it across in a way that, okay, this is a temporary surgery and you're going to have problems later on. You've got to strike a balance in your counseling whereby you tell them that this is definitely successful in many ways, is going to improve you in a lot of ways, including your quality of life. And then as you age, as you grow, as things may change, there are going to be changes that happen.
Rahul, your take on it?
So my conversation at the time of primary surgery also revolves, and I make it very clear. What I've started doing recently, for the last couple of years, is tell the patient that it's a lifelong affair. Sleep apnea. I would want the patient to maintain his current weight as much as he can, and also be on regular exercises. So myofunctional therapy is a must for all my patients, be it pediatric or adults. After simple pranayam also goes in a long way. So idea being, I'm improving the static obstruction part. The dynamicity will stay in a good shape as long as you keep your body in a good shape. What I feel, though, the surgery does provide advantage to the patient, that earlier 5 kgs of weight gain would cause severe worsening of snoring. Now the patient is able to kind of is allowed to cheat a little more. But I tell them surgery will fail if he puts on significant amounts of weight and doesn't do regular exercise at some point in time. So the best insurance against it is regular exercises, regular myofunctional therapy, and to keep his weight in check. That's what I tell my patients. So
Thank you, Rahul. So I think,
Can I add a line?
yeah, because.
Yeah, so see, if I have operated on a young patient, say 28, 30, 35, 40, nothing will change in the next 4-5 years. So I cannot say that your surgery is bound to fail in next 4-5 years because your muscle tone has gone down. If I have operated on nose, if I have operated on a palate which is really long and I have shortened it, that would stay for his next, say, 10 to 20 years. The results should remain as is. And in the last 12, 13 years, I know which patients have not done well, which patients have done well with my own experience. Now, if I have operated on a fat patient who is foodie and who is, I've just got him some relief with my surgery so that he's able to use CPAP, that is a different subset of patients. Old patients if I've already operated at the age of 58, 60 and is aging, then in next 10 years, things will be a change. But if I say that I am operating at the age of 30 and at 35, you will again have a muscle, that's all in my, it's all bullshit.
Agreed, because.
Sorry. So we
I
have
think
to, if we are
it's already
changing
8 o'clock.
that has to, otherwise we should not be operating only. If you are changing anatomy, anatomy is a persistent change, permanent change. It has to give benefit for a long, long time.
Thank you. Thank you for the answer. I think it's already 8. We'll just wind up with this take-home messages. I want each and every one of the panelists to give one take-home message, and then we'll say thanks to all. Deepankar, let's start with you.
So in one word, basically, we are basically gathered here on the occasion of World Sleep Day. So the message is healthy lifestyle. What we consistently say always, obstructive sleep apnea management starts with healthy lifestyle. To percolate this message, before jumping upon any kind of surgery or CPAP, whatever, you maintain a healthy lifestyle like good diet, proper diet, exercise, different kind of sleep, gym, upper airway, functional therapies, sleeping posture change, and counseling is extremely important. If really we are operating, we are a surgical community here. So do a proper, validated, methodically selected, properly selected patient in a proper way, and a proper counseling with documentation is of utmost important.
Thank you. Rahul?
So to extend that further, I would say that start screening your patients for sleep apnea, especially patients who come to your ENT clinic with nasal symptoms, so that we are able to diagnose them well in time, and try to personalize therapy. Don't try to have a one-size-fits-all approach. Try to personalize therapy for each patient. Each patient is unique. Each patient is unique in terms of his need for the surgery or need for intervention, and unique in terms of its anatomy. So diagnose more, create more awareness, and have a personalized therapy for each of your patients.
Sandeep?
I think the most important thing at present time is to create awareness, not only amongst patients, but our colleagues also. You know, our different specialties, pulmonologists, dental, oral max X, that how ENT can help even in the medical management also. And and plus the prevention of OSA, like we have to diagnose it as early as possible so that we can mitigate the ill effects of the cardiovascular comorbidities in these patients.
Sima?
So, Sagar, every time when we give our take-home messages, we are almost all of us are always on the same page. The vocabulary is just different, and each one of us puts it across in a very different manner, but we say the same thing. So it's all about patient-centric approach now. It's all about the fact that the counseling and the right selections are very important. But I think one of the important things that we need to really, really bring out is to our very own colleagues, where people are so skeptical about the results of surgery, is where we need to put across very, very categorically that whatever we speak today is evidence based. And although it's a complete holistic approach, we understand, we've been saying it all, we're keeping it very tailor made, we're doing all of that. But surgeries do play a very important role in the management of OSA, and surgeries do give the success rate that is desired, not just necessarily in terms of statistics, but even in improvement in quality of life of that patient and transforming the life of the patient. So all in all, we need to get this message quite clear that it is a very good option that we have now. And contrary to what was always bombarded to us that we are not evidence-based, there is enough evidence out there to show the improvement in surgeries. Improvement in OSA with surgeries.
Srinivas?
So what I want to say is that OSA is a journey, as we were saying. Once you start it, the patient's going to have it for a very long time. It's very important that we sort of explain this to the patient and communicate what is to be done for that particular patient. Understand your DICE, understand your sleep study very well, and communicate it to the patient. We have gone beyond completely giving CPAP for all or doing surgery for all. We are here in the science of managing sleep apnea. And whenever it is required, please don't shun away from skeletal surgery when it is required. Just because we are an ENT surgeon doesn't mean we just have to do soft tissue surgery. Do skeletal surgery when it is required. And please follow up the patient so that these patients do not suffer from residual disease, which can actually, because OSA is such a dangerous condition, that any sort of residual disease, if it's coming back for whatever reason it is, we sort of try to help them to come out of that particular problem.
Because
I think everything has already been said. Let me summarize it in the form that OSA is as a multifactorial problem. One factor is the obstruction, which is the local factor. One is the obesity, which is a general factor. And one is non-anatomical and non-obesity, like muscle tone and all those palm scale type of factors. So first, if we know that it is an unfavorable palm scale for which the techniques and the methodology is not very clear now, if we are sure that it is on that line, we do not operate. We can operate on the anatomy, soft tissues versus bone, like Srinivas said, nose, palate, base tongue, epiglottis, depending on where is the obstruction. We can remove the obstruction, but obesity is what is not in our control. So there's always a role of, management of that obesity related obstruction with the CPAP. We cannot tackle all areas of the hypopharynx, we know about it. So like Kishore very rightly said, that we should not shy away. Let's help the patient as much as we can with the surgery. And then CPAP is already always there to do the rest of the part. It becomes easier. Or if we have alternative therapies like in acetazolamide and all those things, they're there to help us. It's a multidisciplinarily, multifactorial problem, and it cannot be only surgery, only CPAP, only that therapy. It has to be a combination. And luckily, there are some patients who can do very well with our surgery. Luckily, there are some patients who can do very well with only CPAP, but most of them are not, right?
thank you. Thank you so much. I think it's a very difficult topic to bring out difficult scenarios in management of OSAS surgical management. And without the help of our esteemed panelists, this wouldn't have been successful. So thank you so much, each and every one of the panelists, and thanks for the audience. Now I hand over the session to our president. Thank you, sir.
But before that, wonderful moderation, superb. We all enjoyed it.
Thank you very much, Sagar, for all the
Thank you,
effort that
Sagar.
you have put in. And
Thank you,
to
Sagar.
extract the best from us.
Thank you.
Hmm.
I think
Lovely, Sagar. Lovely points.
Thank you, sir.
Hello.
Sir,
Thank you, Dr. Vijay Sagar. You have moderated the session very well, and the panelists, they have also answered each and every query made by you. Now I request Dr. Gautam Khon to say the vote of thanks. Is Dr. Gautam is available here? Hello.
Yes, sir, I am there.
Yes.
So a big thank you to all the panelists and the moderator for conducting a very lucid talk and discussion on this topic. On behalf of the Indian Academy, I thank each one of you for your participation. You have participated in this series before also, and this particular episode is actually linked to the World Sleep Day, as Dipankar had already mentioned. And we hope the audience has benefited. We would like to thank the GSK, who have been partners in this series for a long time. And again, thank you all very much. Looking forward to your cooperation in the future as well. Thank you.
Thank you very much.
thank you.
Thank you, everyone.
Thank you, everyone. Good night, everyone.
Sir.
Good
Thank
night.
you, IAOHNS.